All right. Welcome everyone to this talk on centering racial equity in Medicare for All. My name is Dr. Sanjeev Sriram, and I am a pediatrician in Maryland. I work closely with Social Security Works, and I am also Dr. America, a health correspondent for WEAC Radio and ACT TV. And the purpose of this talk is really for us to reimagine and reinvigorate the way that we talk about and grow the Medicare for All movement so that it centers racial equity rather than constantly have racial equity be an afterthought or a vanity project for health justice. So let's get started. Okay, so I wanted to kind of start with where we are right now. We're recording on March 23rd, 2022. This is the 12-year anniversary of the Affordable Care Act, also known as Obamacare. And there's no question that under the Affordable Care Act, there was a tremendous amount done to improve inequities between different minority groups. As you can see in this chart, all of the lines for all the different ethnicities are moving downward. That's a good thing. The reason why I put the progress in a question mark is because you still see very persistent gaps. Ever since the Affordable Care Act was enacted, there have been a lot of improvements with the way people have been able to get coverage, but there are still a lot of persistent gaps in that coverage, and our health outcomes mirror a lot of what you see in this chart. And a lot of what you see in that chart leads to the current situation. This is a snapshot of the general population versus the uninsured population just before the onset of the pandemic. And what we learn from looking at this is that the majority of America's uninsured are people of color. So the uninsured population is majority minority, and that might be a term that you've heard referred to with American demographics, and that the country is moving towards a majority people of color nation. And our uninsured population is already there. It is a majority people of color group in our country. And as we kind of dig further into what it means to be a majority minority country, I know many of you may have heard about America turning that direction in 2040, but I would actually invite you to think about 2040 being a 30-year late landmark, that we are actually majority people of color now, because that is the reality in many states. I'm a pediatrician, so I'm biased towards pediatric data. In 2011, over half of infants in the United States were people of color. Also in 2011, the underage 10 child population, majority people of color in these 13 states. The 2014-2015 school year was the first school year that students of color enrolled in public schools outnumbered white students. And in 2018, expanding beyond the pediatric population, people of color became the majority in these respective states. My home state of Maryland, we are over that 49.5% mark at the time of this recording. And so we are the first majority people of color state on the East Coast, with many states soon to follow. And just at the onset of the pandemic, the majority of America's children are people of color. So it helps to kind of keep in mind that the country's demographics have already rapidly changed. There's no need to wait for a landmark 20 years from now. It is happening right now. So given that this is who we are right now, we have to ask ourselves, are we doing right by America's uninsured? This is a chart that comes from fact sheets from the All Means All campaign that I lead at Social Security Works. And I'm using Maryland because it's my home state. The majority of our state's uninsured are people of color. There's pre-pandemic, it was 355,000 Marylanders uninsured, 73% of whom are people of color. 87% of those uninsured were from people who were employed, or families with employment, and 78% were earning less than $50,000 a year. So this this is the reason why I pick on Maryland. One, of course, I live here, but the other element of this is that this is a blue state that has always embraced the Affordable Care Act since it was enacted. It has done the best that it can under the ACA, and yet we still have this huge disparity in coverage for our people of color in Maryland. And there are many, many states that follow this similar pattern. In my research, there was not a single state in the country where being a person of color or being uninsured was not a racial injustice. Again, there's not a single state in the country where being uninsured is not a racial injustice. And so when we turn now to the COVID-19 pandemic, we find that a lot of what the virus has done is exacerbated what has already been a pandemic of its own in terms of racial inequity. As of the spring of 2020, 78 million people had lost their jobs and 27 million lost their insurance from employment. Of those 27 million, you can see this breakdown of who was eligible for Medicaid, who was eligible for subsidized ACA plans. And then there's just under 6 million people who were quote unquote ineligible because of so-called high incomes, their citizenship status, living in a state that had not expanded Medicaid, and any number of other excuses. But overall, what the pandemic has taught us is that this fragmented system is failing. It was failing before the pandemic. It is failing even harder now. And again, in my home state of Maryland, the uninsured rate went up to 11% at one of the worst times of the pandemic. Under the COVID-19 virus has been particularly devastating for our brethren of color. Black and Latinx people are 3 times as likely to get infected and twice as likely to die compared to their white counterparts. And the causes of these inequities are indeed structural. There's nothing biological about any of this. There's nothing that you can say about the genetics or biology of Black or Latinx people that explain why COVID-19 has been particularly devastating. The fact of the matter is that only 1 in 5 Black workers and only 1 in 6 Latinx workers have been able to work from home, and they disproportionately work in high-risk environments where their labor is essential, but the workers themselves are treated like they're expendable. And while many in public health might point to these communities having a high rate of chronic medical condition and undiagnosed illnesses, again, I would say that this is not a function of biology. This is a function of unjust and racist structures that we have in America, where people are consistently and targeted in a way for being chronically poor, unhoused, hungry, and with inadequate transportation. And couple that with a long history of unequal medical treatment and discriminatory policies, and the COVID-19 pandemic was open for devastating these families. And so once again, pandemics and our current healthcare crises and inequities are failures of policy, not people. So now more than ever, it was the time for Medicare for all. And on the ACA's 12th anniversary, I do want to point out that it is an important piece of policy, but it is clearly insufficient. The Medicaid provisions under the ACA, they work, sort of, depending on where you live. Even in a blue state like Maryland, there are a lot of obstacle courses between being uninsured and having Medicaid coverage. And even once you have the coverage, there's a good chance that you're working with the managed care organization, which is how private insurance gets their hands on Medicaid patients. And they are then struggling with what many privately insured people struggle with, and that is that they're dealing with a private insurance system that is unjust, unreliable, and consistently throwing unaffordable obstacles at them. And this current fragmented system is simply unsustainable. And I consider the current system, that's status quo, to be far more unrealistic than anything that Medicare for All is proposing. Right now, the questions that determine your access to healthcare, this is not just whether you have coverage, but also your ability to get care, because we know that coverage and care are not the same thing. But these questions about how much money do you have, where do you live, baked in these questions, which might not seem racist on the surface, are a ton of racial inequities. Because the intent of asking, how much money do you have? The intent of asking, where do you live? Is rooted in racist paradigms such as states' rights and a capitalist apartheid system that constantly values your money over your life. And racial inequities are the product of basing our healthcare on these unjust questions. When really it should just be, are you a human being? Great, here's your healthcare. And so right now, healthcare is a privilege and not a human right, as we all know. Now, this brings us to Medicare for All. And one of the frustrations that I have had personally with the way that we talk about Medicare for All is that we are constantly looking across oceans to other parts of the world. And, we are so many people who I admire and respect dearly constantly love to bring up places such as the UK and Scandinavia. And the reason why this frustrates me is because I have to bring Medicare for All to my patients in places like Central Maryland, where there's a huge and growing immigrant population. I have worked in Southeast DC, which is predominantly Black, and I trained in South LA, which is predominantly non-white. And, to talk about Scandinavia in these communities, you may as well be talking about Westeros from Game of Thrones. And to say that, single payer works great from Stockholm to Amsterdam is as good as saying that it works great from Winterfell to King's Landing. It really just sounds like white peopling. And so what I encourage us to do is to re-examine our ways of thinking about, talking about, and growing the Medicare for All movement, such that we're actually addressing racial inequity at home, because that is a huge part of who we are and who we need to evolve past. So this is America, and the text actually shows what this picture is trying to demonstrate, and that is that 62% of Black people and 64% of Latinx people earn less than $40,000 a year compared to their white counterparts. And only a third of Black people and a third of Latinx people have incomes that are between $40,000 and $120,000 compared to half of that of whites. And so this system of where we are in America is uniquely ours. This is a huge part of how American capitalism works, it depends on these kinds of racial inequities. And we will not be able to build a healthcare system unless we confront these kinds of inequalities that are wreaking havoc on people's lives. 69% of Americans in general do not have $1,000 in savings, and 40% of Americans don't have $400 for an emergency. And these numbers come from the chart comes from Pew Research. The stat about the 69% of Americans not having $1,000 in savings comes from the banking industry, and 40% of Americans not having $400 for an emergency comes from the Federal Reserve. So, this is not left-wing data whatsoever. This is most definitely from moderate think tanks and researchers, and it still shows glaring inequities of who we are and who gets to have financial and wealth power in this country and who does not. And so I want to use that as a context for centering racial equity in Medicare for All and encourage us to confront these barriers directly. And so rather than talking about how Medicare for All compares and what it would mean as far as like bringing the United States up to its predominantly white peers in Europe, I'd rather us, focus on how we need to make healthcare in America a human right, no matter what you look like, what you earn, or where you live, because these are the right now the determinants that are either opening doors or closing them to healthcare, and it's a uniquely American issue. And when we talk about ending the hassles and hustles of healthcare, again, this is something that my patients and people of color know all too well, that your healthcare can flip on a dime just from changing jobs, from moving from one state to another, or from going through a normal life event such as graduation, returning to school, divorce, retirement. If you become disabled, any of these just normal life happenings can dramatically change your ability to have coverage and care in the American healthcare system. And by focusing on this, we actually start to bring healthcare and the potential of and the promise of Medicare for all more concretely in the lives of people of color. So returning to the pain of a $400 emergency, that pain is not equal across various communities. And this is a chart that comes from the Federal Reserve, and what it shows is the dark blue are the percentage of people not able to fully pay their current month's bills. And you can see that as people have more education across ethnicities, they are able to still, they're able to pay their bills better. But even with a college degree, over a fifth of Black Americans struggle to pay their current month's bills. Over 1 in 6 Latinx people are struggling to pay their bills. And then when you add in a $400 emergency, which the Federal Reserve, clearly states that healthcare does throw these kinds of emergencies at people, you find that it goes up from being 1/5 of Black people to almost 1/3 of Black people struggling to pay their current month's bills just from a single $400 emergency. And it nearly wipes out the degree that they got. It almost puts them back to where their peers are who've only had some college or an associate degree. And so we have a healthcare system that, because of its drive for profit and its disregard for people's willingness to struggle with their finances and hustle and sweat for progress, that disregard makes a $400 emergency so devastating and wipes out years of hard work, where you can see for any group, it really does create a major setback. And yet for some groups it's a bigger setback than others, and it's the same $400. And yes, healthcare should not wreck years of hard work and sacrifice. So I want to kind of again bring Medicare for all concretely down to where people live, and what does it look like, what will it feel like, and what does it actually mean for me where I am? Not how does my abstract country compare to other countries, but how about for me in my neighborhood? And I bring this up because for all the times that I've talked about Medicare for all in the communities that I've served, the honest to God truth is that none of them have had to ever look across an ocean if they wanted to see white people with good health care. In Southeast DC, you can look across the Anacostia River and you see that there are people, in Georgetown, Foggy Bottom, with excellent health care, and a lot of the time that both sides of that river are looking at the inequities and asking themselves, why can't we just take whatever we're doing in Georgetown and bring it across the river to Southeast DC? And the problem with that is that you have a lot of political leaders who ask that question. You have private equity firms that are asking that question. And none of them are actually asking that from the vantage point of wanting to make racial equity a goal, but they're trying to bring a profit model to places that do not have the money to sustain that profit, and are also just simply not about healthcare. And so you still continue to end up with situations where there are no labor and delivery wards in Southeast DC. Women have to travel across the city to deliver their babies, and that is a situation that happens across so many cities in America that to look across oceans and compare healthcare systems is kind of ridiculous. Like, you really only have to look across the county line. Maybe you have to look up a couple of exits on a highway, or as I mentioned, across a river, and you can see people having great healthcare. And so what we need to do when we talk about Medicare for All is make it much more local and concrete, and really expand people's imaginations right where they are, not ask them to, think about and admire what's going on a globe away. And so what I prefer to focus on is that with Medicare for All, hospitals and clinics don't close or relocate or remove their services just because they're located in poor neighborhoods or happen to serve a large number of poor people. That that your local hospital, the United Medical Center just down the street on Southern Avenue, that your local clinic, that you've gone to for years and have always seen struggle, that these places of healthcare that have served your family will continue to do so, and will actually do a better job doing it because they're not constantly trying to figure out how to keep the lights on and how to do their most basic work. And so to know that you have that stability and reliability of healthcare where you live is a huge advantage that Medicare for All has over any number of competing policies, including the Affordable Care Act. And so again, we have to be sure to amplify local stories and local pain and make Medicare for All a very real answer to those circumstances. Again, because of global budgeting, community hospitals and clinics will have reliable funding to stay open with high quality staff and resources. And so as much as global budgets are often kind of sidelined as a wonky financing tool for Medicare for All, to me, they're actually a huge key to how we build racial equity. And I encourage people to learn more about global budgets in that context. In both the House bill and the Senate bill that Senator Sanders introduced a few years ago, there are provisions for funding to maintain racial equity across hospitals and clinics, meaning that no matter where you go for care, you are going to be treated fairly, at least under the law. And that's a huge step in the right direction for a country like ours that is rapidly changing its demographics. One of the things that I emphasize whenever I talk about Medicare for All in the communities that I serve is that by no means is Medicare for All a cure-all for all racism or injustices in healthcare. That what we are talking about is policies to dismantle some of the worst structures that we have, but that the culture of medicine itself must still go through fundamental changes from the root to the fruit, and that there's no avoiding the fact that we've got a lot of work to do. So in summary, I wanted to just sort of give us the TLDR version of this talk, and that is I encourage you to confront barriers directly, and that histories of our current fragmented healthcare is rooted in segregation, and we should be upfront, honest, and courageous and bold to say so, and to discuss that, and to talk about how we're going to move from here to build something better and new. That we should be willing to amplify personal, everyday struggles, and that we need to be able to hit the pause button whenever we have, as a community or as even as individuals, when we've been accepting the unacceptable, we should be encouraging ourselves to pause and ask, how the hell did we get here? Why are we still doing this? And is there not a better way? And giving ourselves that permission to reimagine healthcare with justice and equity at its center, I think actually gives people a chance to re-examine what they have tolerated for so long, so unfairly. And again, Medicare for All has to be a living, breathing thing in people's, in communities where they live, where they actually are. We need to stop asking them to look across the oceans to compare healthcare systems, because too often the insult and the injury are right in their faces. They look no further than a river or a highway, and they'd see the dividing line of where good healthcare and no healthcare exist. And so by talking about and confronting that inequity and discussing what Medicare for All's role is in that, I think that we can really build this movement and encourage new, fascinating, and uplifting dialogues for people. And I did not get to touch on this, but immigration is a huge barrier for so many of the people that I take care of. And it too is rooted in so much racial inequity. And when we decide that immigration status and citizenship um, are are worthwhile barriers, then we have to understand that we are hurting everybody, including citizens, by blocking some people from healthcare and not others. And that again, we need to confront the racism that is at the center of why we have such inequities across immigrant communities versus citizens. And again, let's be real, Medicare for All, as awesome as it is not going to end all racism. So I want to thank everyone for listening to this talk. To learn more, I have fact sheets for every state and for every congressional district. Right now, the data at this website, socialsecurityworks.org, all means all CD reports, this data is all pre-pandemic. And so I encourage people, if you are going to use these fact sheets, which you absolutely should, is to just reframe the dialogue as saying, this is not the normal that we want to return to. When Maryland had 73% of its uninsured as people of color, that is not a normal that Maryland should return to. And that's a talking point that can be replicated for any number of states and congressional districts across the country. And I'm happy to share what I can and work with all of you from All Means All and from whatever help that the movement needs. And thank you so much for listening to this talk. And yeah, please reach out and let's collaborate. Thanks again. Bye-bye.